Okay, good night, everyone. I'm Tiffany Anthony. I work in the neurosurgery departments in Port of Spain. And tonight I will be presenting the cervical spine, more focusing on the trauma. So we'll be covering the C-spine anatomy, cervical trauma, and general management of it. Right? So those are the basic objectives of this lecture, essentially. Right? The anatomy, trauma, and general management of cervical spine trauma. So just a quick overview of the C-spine anatomy. So it's made up of 7 vertebrae, and the C-spine develops lordosis. And this is a curve that is convex anteriorly and concave posteriorly. And in the adult, it's maintained by the larger superior to inferior dimensions of the anterior portion of the intervertebral disc. Because this curve is primarily created by the pliable intervertebral disc, traction of this region reduces the cervical lordosis. So the vertebrae are actually split into typical vertebrae, that's the C3 to C6, and the remaining 3 are considered the atypical vertebrae, C1, C2, and C7. And the vertebrae C3 to C7 are called the subaxial spine. Right. Here's just a diagram of the entire vertebral column. Here specifically focusing on the cervical lordosis. So it's usually 20 to 40 degrees in curvature. And the cervical spine supports and moves the head and transmits the spinal cord and vertebral vessels between the head and the neck. Right. So just a breakdown of the typical cervical vertebrae. So the different parts. So you have the body, which is rectangular and has an Usane process, and this is on the superior aspect of the lateral sides of the body. You have the pedicles, which are small. They have superior and inferior vertebral notches where the nerves will come out, the transverse processes. You have the anterior and posterior tubercles, and especially here, the foramen of the transverse processes. The articular processes, posteriorly, superiorly, and here, the laminae, which are short from superior to inferior. A special note, the spinous processes are bifid here in the cervical spine. The intervertebral foramen are oval shaped, and the vertebral canal is actually the largest in the C-spine. It's a trefoil shape. And as said previously, the typical vertebrae are C3 to C6. Here's just another view of it. So here you actually see in the, here you actually see in the Usane process a little more clearly there on the top, the spinous process and so on, and the notches below. Just another diagram here. So just a special note as well for even though C6 is considered part of the typical vertebrae, there's a carotid tubercle where the left and right anterior tubercles where they're prominent, and the carotid artery is very closely related to this vertebrae. And clinically, the carotid artery may be compressed in this groove here. And moving on to the atypical vertebrae. So starting with C1 is also called the atlas. So it has no body or spine. It consists of a right and left lateral mass connected by a short anterior arch and a long curved posterior arch. The anterior arch consists of a tubercle and an articular facet for the dens on the posterior surface of it. The posterior arch is equivalent to the lamina of the typical vertebrae and has a posterior tubercle with the equivalent spinous process, equivalent to the spinous process. So here, in this diagram, so you're seeing the anterior arch. Just posterior to that would be where the dens of the axis would communicate with. You see in the transverse processes, the superior facets. The other one, you'll see the inferior facets on the different views. Yeah, there's another diagram. Here, I think you're seeing the facet for the densal more clearly on this one. So the C2. C2 is also known as the axis. Special things about it. So it has an odontoid process or dens, an anterior articular facet that articulates with the anterior arch of the atlas to form the median atlantoaxial joint. A posterior articular facet, it has a bifid spine. Of note, the transverse process, the foramen, the vertebral artery exits here and makes a 45-degree turn and re-enters the C-spine at the foramen of the transverse process of C1. It also has a lateral mass, superior and inferior articular facets. So seeing here the superior and more the anterior view, you can more appreciate the dens there, seeing the facets and the vertebral body. Just some more diagrams showing it, just to make it everything clear in everyone's mind. Okay, this is just an X-ray of the open out view where you can actually visualize the axis a little more clearly here. This is just a table, just summarizes nicely the similarities and differences of the atlas and axis. So similarities in the axis, the spinous process and the vertebral body, just like the cervical vertebrae. Both have transverse processes with foramen for the vertebral artery and articular surfaces on the lateral masses. So differences with the atlas, so the typical cervical vertebrae, it has a posterior arch in place of the lamina, posterior tubercle in place of the spinous process, an anterior arch with an anterior process. Of note for the axis, the dens or the odontoid process, articular process in place of the lamina. Now, both don't have uncinate processes or lateral masses in place of the body, right? C7 now. So C7 has a very prominent spinous process seen here in the diagram. Has a vertebral foramen, seen the lamina, the transverse process, the foramen of the transverse process, right? So yeah. Of note, the foramen for the transverse process is smaller than the others. So this is the only vertebrae that has the only the vein coming out from it. From C6 upwards would have both the vein and the artery coming through the transverse processes on either side. Just another diagram showing the two vertebrae, the C7 vertebrae, sorry. So now to the joints. So the occipito-atlantoaxial complex anatomy. So this is very important to note. So the ligaments provide stability to this, right? It's really primarily due to the ligaments, not really for the articulations that take place. So you have three main focuses. So the ligaments that connect the atlas to the occiput. You have the anterior atlanto-occipital membrane, the posterior atlanto-occipital membrane, the ascending band of the cruciate ligament, and that make up that. And you have the ligaments that connect the axis to the occiput, the tectorial membrane, the alar ligaments, and the apical odontoid ligaments. Then you have ligaments that connect the axis to the atlas, and that would be the transverse atlantal ligament, which is the transverse component of the cruciate ligament, the atlanto-alar portion of the alar ligaments, and the descending band of the cruciate ligaments, right? So here's just showing a table kind of summarizing the original insertion, and of course a diagram to help us kind of clear it in our minds. So here you see the anterior atlanto-occipital membranes with limits extension of the head. The lateral atlanto-occipital membrane limits lateral flexion. The posterior tectorial membrane restricts extension at the atlanto-occipital joints, and it's a continuation of the posterior longitudinal ligament. The posterior atlanto-occipital membrane is a posterior reinforcement of the joints. The nuchal ligament restricts hyperflexion of the cervical spine, and it's continuous of the supraspinous ligament. The Barcus ligament, more you see on this side, and that limits the extension of the atlanto-occipital joint. Right. Now you have the atlantoaxial ligaments. So the cruciate and the alar ligaments. So the cruciate ligaments maintain stability of the atlantoaxial junction by locking the odontoid process against the anterior arch of C1, and it's the strongest ligament of the atlantoaxial joint. The alar ligaments limit hyperrotation and lateral bending on the contralateral side. The transverse occipital ligament sits posterior superiorly to the alar ligaments and assists them in support of the cranocervical junction. Then the posterior ligament, you have the accessory atlantoaxial ligament, which provides protection and support for the branch of the vertebral artery that supply the dens. The tectorial membrane, which restricts flexion and extension of the atlantoaxial joint, and the Lucal ligament, again, which restricts the hyperflexion of the cervical spine. So here's just some more diagrams, just so that everybody's clear on the structures that we're talking about here, because that'll come into play with the clinical stuff for the trauma. So ligaments of the subaxial spine, the anterior longitudinal ligament, it's wide, it covers the anterior aspect of the vertebral column, of the vertebral body, sorry, and this from the occiput to the sacrum. The posterior longitudinal ligaments, which is the inferior continuation of the tectorial membrane. Then you have the nuchal ligament, which extends from the occipital protuberance to the C7 spinous process. The ligamenta flava, which are paired ligaments left and right that run between the laminae of adjacent vertebrae and found throughout the spine and become thicker inferiorly. The interspinous and supraspinous ligaments and the intertransverse ligaments. So here's another diagram showing that. Here you see a little more clearly to where the vertebral artery will pass, the attachment to the different ligaments here on the right. So the joints of the C-spine, you have the intervertebral joints, and those would be between the vertebral bodies. So you have the joints between the articular surfaces and the vertebral bodies. That's with the intervertebral disc joint, or a symphysis joint. And then the joints of von Luschka, which are unconvertible joints. And those are the joints between the uscinate processes of the vertebrae of C3 to C7. That's where you have the uscinate processes and the inferior aspect of the vertebrae above. They are found lateral and anterior to the intervertebral foramen on each side, and on each side of the relevant intervertebral disc. Then you have the verts between the joints between the vertebral arches themselves, called zygopophyseal joints, or Z joints, or facet joints, between the superior and inferior articular processes of adjacent vertebral bodies. And then the craniovertebral joints, so between the occiput and the C1, C7 vertebrae, so the atlanto-occipital, between the occipital condyles and the superior articular facets of the atlas, the atlantoaxial joints, which are one median and two lateral and atlantoaxial joints. Here just showing the anatomy of the intervertebral disc. So it's a fibrocartilaginous structure, which is made up of the annulus, annular fibers, and inside the nucleus pulposus, annulus fibrosus, and the inner gelatinous core called the nucleus pulposus. It's about 7 to 10 millimeters thick and 4 centimeters in diameter, and collectively, the discs contribute to about a third of the length of the vertebral column. Here's just showing you a diagram of the joints in between, the facet joints, the joints between the vertebral bodies here. Seeing the median atlantoaxial joints. So here's just a diagram of the entire vertebral column. Here you kind of seeing some of the articulations going down. And this one, you can more appreciate the facet joints in between the subaxial vertebrae here, and just a posterior view of the C-spine, and just an x-ray here so everybody could appreciate the anatomy while viewing an x-ray, a lateral view. Okay, the blood supply. So the vertebral arteries originate from the subclavian artery and ascend between the anterior scalene and the longus colli muscles. It has 4 segments, V1, V2, V3, V4, and they enter the spine at the transverse foramen of C6. The spinal cord has one anterior spinal artery and 2 posterior spinal arteries and segmental medullary arteries that supply it. Here's just a diagram showing you where the vertebral arteries will run. So just of note, so the arteries and veins will run together, but the vertebral artery will start from C6 to C1, where the vein will actually start from C7 and continue onwards to C1 and enter the cranial vaults via the foramen magnum, right? Here's just another diagram showing the blood supply here of the spinal cord. And a little more detail here showing on the right, showing where the spinal nerves would exit, along with where the veins and arteries run along the vertebral column, the C-spine. Here's just showing the vertebral bodies with the spinal cord inside, showing where the spinal nerves will come through the intervertebral foramen. This is just showing the dermatomes of the spine. This is just a diagram, just because the spinal cord will be parts of the anatomy here. So the cervical part of the spinal cord is actually the thickest part. In terms of the anatomy, you have the gray and white matter. The gray is found more midline, organized in the structure, labeled accordingly here, and would have labeled accordingly to their different nuclei and then their functions. Wouldn't go into too much detail into the tracks, right? But this one will show more the white matter tracks, the ascending and descending tracks, of the myelinated axons, right? It's just a table, again, summarizing the different tracks, the ascending, descending. This is just a diagram showing the muscular anatomy of the neck. Excuse. Yeah. Right, seeing the longus colli and anterior scalene muscles, the triangles of the neck. The carotid triangle is also something that I believe is something very important to take note of, especially when we have to do the anterior corpectomies and discectomies, those surgeries. So within that, you'll have the carotid sheath, and that contains the internal jugular vein, the common carotid artery, and the vagus nerve, seen here in this diagram. This is just another diagram showing the spinal nerves and the corresponding dermatomes. So movements of the C-spine, we have flexion, extension, lateral flexion, and rotation. Okay, so more on to the clinical side of things. So spine injuries, and we're focusing more on C-spine injuries. So 20% of patients with a major spine injury will have a second spinal injury at another level, which may be non-contiguous. These patients often have simultaneous but unrelated injuries, example, chest trauma, traumatic brain injury, etc. And of note, definition for spinal stability, coined by White and Punjabi, is the ability of the spine to undergo physiologic loads to limit displacements so as to prevent injury or irritation of the spinal cord and nerve roots, including the quadrate equina, and to prevent incapacitating deformity or pain due to its structural changes, right? So this diagram here, I just put in because this shows, I believe, is the Dennis classification, where it divides the spinal column in the vertebral column into three columns, essentially the anterior, middle, and posterior. And if two or more injured, essentially that equates to spinal instability. So here we have whiplash-associated disorders. So whiplash was at first a late term. It's currently defined as traumatic injury to the soft tissue structures in the region of the cervical spine. This is including the cervical muscle, the ligaments, the intervertebral discs, the facet joints, etc. This could be due to hyperflexion, hyperextension, or rotational injury to the neck in the absence of fractures, dislocations, or intervertebral disc herniation. It's the most common non-fatal automobile injury, and symptoms may start immediately, but more commonly are usually delayed to several hours or days. In addition to symptoms related to the cervical spine, common complaints associated with it are headaches, cognitive impairment, and low back pain. So this is just a clinical grading of whiplash-associated disorders, the severity. So you have it graded from 0 to 4, 0 being with no complaints, to 4 having symptoms. So symptoms could be neck pain, stiffness, or tenderness. And then from 2 onwards, you have symptoms along with some type of clinical signs, some reduced range of motion, tenderness, sensory deficits, absent reflexes. And then in evaluating, so grade 1, patients with normal mental status and a physical exam do not require plain radiographs on presentation. If they are grade 2 and 3, then we should do C-spine x-rays, possibly with flexion extension views. The special imaging such as MRI, CT, myelography are not indicated in these patients. From grades 3 and 4, these patients should be managed as a suspected spinal cord injury, given the nature of their clinical presentation. And you should treat them accordingly as a spinal cord injury, which we will go into a little later. So the treatment of whiplash-associated disorders. So this table summarizes it pretty well. So generally, from grades 1 to 3, the general thinking is that they should start moving. So they should have their range of motion exercises as soon as possible, immediately. Once they can tolerate it. From grade 2 to 3 onwards, maybe you could consider cervical collars and rest, but for no more than 3 to 4 days. And we can recommend other things too, like heat and ice, massage, TENS, relaxation techniques, and medications are optional, like the optional use of NSAIDs, non-narcotic analgesics, usually for no more than 3 weeks. And in these patients, surgery is not indicated, right? So here they have surgery only for progressive neurological deficit, but in this case, then you would need to further investigate the patient and see there might have been something missed or something now developing. Here's just an example of the TENS machine. Okay, so whiplash. So in terms of their prognosis, usually by 3 months, 56% of patients recovered, and it increases thereafterwards. So 6 months, 70%, at 12 months, 76%, and by 24 months, 2 years, 82% would have recovered. Okay, cervical spine trauma. So generally speaking, so in the field, it's just like any trauma. So you do your ABCs, airway, breathing, circulation, and spinal immobilization with a rigid cervical collar, lateral boosters, and a rigid backboard. Once you reach the hospital in the emergency department, well, it's the same thing if the patient presents their ABCs, and then you can add the disability and exposure at that point. Standard imaging, the x-rays, And here the patient could have like a combination of neurogenic and spinal shock, usually with hypertension, bradycardia, and it can be managed with vasopressors and modest fluid resuscitation. And then you can classify spinal injury according to the American Spinal Injury Association, or ASIA scoring scale, which you can see here in this table. So it's class A, B, C, D, and E. So class A is complete, no motor or sensory function preserved. B, and incomplete. So there's sensory but no motor function preserved below the neurologic level. Class C is incomplete, motor function preserved below the neurologic level. More than half of key muscles below the neurologic level have muscle strength less than grade 3. Class D, incomplete motor function preserved below the neurologic level. More than half the key muscles below the neurologic level have muscle strength more than or equal to grade 3. And E is normal. Sensory and motor function return to normal. And table below is just a reminder of the muscle gradient system from 0 to 5. This is just a table summarizing the injury patterns that you can have with the spinal cord. So you can have a central cord, usually due to an hyperextension injury with greater upper extremity involvement and more proximal than distal muscle groups. The prognosis for this is fair. You can have an anterior cord injury due to injury of the anterior spinal artery, get a loss of P in temperature and motor. Prognosis for this is poor. There's the Brown-Séquard quad. Due to hemitransection of the spinal cord or lateral injury, you have ipsilateral motor loss, vibration and position sense, and contralateral pain and temperature. Prognosis for this is the best. And then you have the posterior cord injuries, loss of vibration and position sense. Prognosis is fair. So here, so this and the following slide, we'll go into basically when you should consider doing radiography for patients who present with spinal cord injury, right? So there's the National Emergency of Radiography Utilization Study Criteria, the Nexus. So you go through all these. If there's no posterior midline cervical spine tenderness, no evidence of intoxication, a normal level of alertness, no focal neurological deficits, no painful distracting injuries, then no, the patient doesn't need radiography. If yes, then proceed with that. This, however, wasn't not found to be superior to the Canadian C-spine rule, which is a little more detailed. So this one, though the criteria are very similar, this is the one that is, well, it was found to be a little more sensitive and specific compared to the Nexus criteria. So this one is a little more valid to use. However, it was not endorsed by the Eastern Association of the Surgery on Spine Trauma. But let's still go through the Canadian C-spine rule. So any high-risk factor that mandates radiography, so age more than or equal to 85 years, or a dangerous mechanism of injury, paresthesias in the extremities, yes, radiography. If not, then you go down, are they at low risk? Any low risk factor that allows scale for assessment of range of motion. So were they in a simple motor vehicle accident? Are they in a sitting position? Were they ambulatory at the time? A delayed onset of neck pain? Are they able to actively rotate their neck? If the answer is yes, any of these, then no. However, if they're unable to do any of these, then yes, we will go to radiography. And just of note for dangerous mechanisms, so that could be a fall from more than 1 meter down or down 5 stairs, an axial load to the head, such as diving, high-speed motor vehicular accident that's more than 100 kilometers per hour, rollover or ejection from the car, motorized recreational vehicles, a bicycle collision, pushed into oncoming traffic, hit by a bus or a large truck, or hit by any high-speed vehicle. Okay. Just of note, awake patients with, so in general, in summary, usually awake patients with no neurological symptoms or neck pain or no distracting injuries with a full painless range of motion at the neck do not require immobilization or imaging. So this is also another criteria that can be used for evaluating patients that should undergo a CT angiogram, because as we went over previously, the vertebral arteries are very closely associated with the C-spine and therefore can be injured in these types of high energy traumatic injuries. So we need to be aware of when we need to evaluate patients more thoroughly in this regard. So the Denver criteria here divided into signs and symptoms of a bulbar cervical dissociation injury and the risk factors. So patients with any of these should be considered for a CT angiogram. Treatment is generally anticoagulation and antiplatelet therapy. So the signs and symptoms to look out for are focal neurological deficits, especially with an examination inconsistent with the patient's CT head. So like a stroke on CT head, arterial hemorrhage, expanding hematoma, cervical bruit. Risk factors, things to look out for, I look for 2 or 3 fracture, basilar skull fractures involving the carotid canal, cervical spine fractures, especially those involving a transverse foramen, diffuse axonal injury with a Glasgow-Coma scale less than 6, or anoxic brain injury with hanging or near hanging mechanism. So general management. So of note, 10% of these patients would have non-contiguous fractures. As we kind of went through the x-rays, the radiographs, the CTs, depending on injuries that we will go into a little later, might require reconstruction, might require angiography, depending. MRI is usually required in all cases with neurological impairment or deficits. Now, the use of steroids is controversial. It has limited efficacy and a high rate of complications. And usually, in terms of once surgery is decided, the surgical timing usually is surgical decompression within 24 hours. And this has been shown to lead to statistically significant improvements in the neurological function 6 months after the injury. So, upper cervical spine trauma. So we have atlanto-occipital dissociation, atlanto-axial subluxation dislocation, occipital condyle fractures, atlas fracture, axis fracture, and traumatic spondylolisthesis of C2, and Dens fracture. So atlanto-occipital dissociation, or AOD. So okay, so back to the atlanto-occipital dissociation. So it's a disruption of the stability of the craniocervical junction, which results from ligamentous injuries. Clinical suspicion is paramount in these injuries. The mechanism is a high-energy rotational or flexion extension force. Patients would usually have derangements in their cardiorespiratory parameters. Most mortality results from anoxia due to respiratory arrest from bulbar cervical dissociation. Of the survivors, 40% are quadriplegic, 40% are hemiplegic, 20% are neurologically normal, with neurological deterioration that can occur in up to 35% of patients who live through the initial injury. It's a very serious injury. So the clinical presentation. So they may be neurologically intact. As stated before, with bulbar cervical dissociation, occurring at or above approximately C3, it will produce immediate pulmonary and often cardiac arrest. They may have lower cranial nerve deficits, plus or minus cervical cord injury. They can also present with Bell's cruciate paralysis, which is bilateral upper extremity paralysis with minimal or no lower extremity involvement due to compression above the pyramidal decussation, which is inferior to the medulla oblongata. A worsening, and of note, worsening neurological deficit with application of cervical traction, right? Which is why I usually check spine x-rays after applying the traction and change. And this can happen after changing the meats as well. So the imaging. So x-rays, radiographs, you verify that the film is a true lateral. Multiple measurements have been described. None is usually universally acceptable as superior. A lot of people talk about the powers ratio, the ratio of the distance from the bastion to the C1 lamina, which is divided by the distance from the opistheon to the anterior ring of C1. The next slide will show a diagram of that. CT also with bony windows, especially the sagittal views, and specific things to look for like blood in the basal cisterns and or retroclival hematoma. So this one, so this initial table, it shows the powers ratio. So less than 0.9 is considered normal. From 0.9 to 1 is a gray zone indeterminate. And once it's more than or equal to 1, it's found in, it interpreted as a AOD, right? The table below is the trailiness directional classification of the atlanto-occipital dislocation. So the type 1, where it's an anterior dislocation, so it's the atlas is pushed forward, longitudinal distraction, and then you have in type 2, and then type 3 posterior dislocation. And this diagram just, I think, shows it just a little more clearer to picture it in your heads of how the dislocations are. In type 1 is anterior, type 2, it's pushed superiorly, type 3, and posteriorly. Okay, so radiographic evaluation. So here you have the different measurements that he would use to evaluate the atlanto-occipital dislocations. So you have the BEI, the bastion axial interval, the distance from the bastion to the rostral extension of the posterior axial line. It's also known as the Harris line, and the BDI, the bastion dental interval, so the distance from the bastion to the closest point on the tip of the dents. So this table basically breaks down what would be the normal values on the plain X-ray versus the CT. So here for the BI and BDI, it should be less than or equal to 12. Anything more than, we're looking at a AOD. Now, this is unreliable for the pediatric because of the variable ossification and fusion of the odontoid tip. Here's another one, the atlanto-occipital interval, or the condyle C1 interval. Distance between the occipital condyle and the superior articular surface of C1 measured on a lateral X-ray or sagittal CT reconstruction. Right. Again, so you see any normal values here, plain X-ray versus a CT. Then here you have the powers ratio. Of note, this, however, cannot be used with fractures of the C1 or foramen magnum, and it's only for anterior atlanto-occipital dislocations. So here it's a ratio between the bastion to the posterior arch of C1 over the anterior arch of C1 and to the opistheon. Some more methods. You have the X-line method, also known as the occipital axial lines method. requires the identification of 6 reference points with 2 lines of 6 reference points, 2 lines, sensitivity is 75%. The C2O line from the posterior inferior corner of the access body to the opistheon should intersect tangentially with the highest point of the C1 spinolaminar line, and the BC2S line from the bastion to a midpoint midway on the C2 spinolaminar line and should intersect tangentially with the posterior superior dens. Then if you choose to do MRI, abnormal MRI findings would include abnormal high signal on the T2 weighted images with occipitolateral joints or in the posterior occipitoatlantal ligaments. Very sensitive, approximately 100%, but not specific for an unstable atlanto-occipital dislocation. Okay, general management. So the initial management, once suspected, you should immediately immobilize the neck with a halo orthosis or with sandbags. Cervical traction to reduce these are contraindicated because there's a 10% risk of a neurological deterioration. Now, it's controversial whether operative fusion versus using prolonged immobilization, that'll be 4 to 12 months with a halo brace. However, posterior occipital cervical fusion is usually recommended. Here, just a table summarizing the grading and the management. So, grade 1, no abnormal CT criteria with only moderately abnormal MRI. Management external orthosis with a halo or collar. 2, more than 1 or 1 abnormal CT criteria or grossly abnormal MRI findings in the occipitoatlantal joints, tectorial membrane or alar or cruciate ligaments. Management is surgical stabilization. In terms of the prognosis, the most important predictor of the outcome is the severity of the neurological injuries at the time of presentation. And among survivors of this initial injury, those with severe traumatic brain injury, brainstem dysfunction, or complete bulbar cervical dissociation all had a poor outcome. Those with an incomplete spinal cord injury or non-secure traumatic brain injury may improve. Moving on, we have occipital